Good afternoon once again. I'm sorry for this back and forth. I kind of put one additional case based on the talks that happened during the day. So I said because of the entities being discussed, we should have a look at the morphology as well. I hope it opens here. Uh, I understand that I stand between you and lunch. So I will try to be quick and, I hope the cases make it worth your while. So uh, let's start. So this is, let me just see if this case is opening. Yeah, this is. So while it is opening, we'll just have a look at the morphology. So this is a 66-year-old woman with bleeding per vagina for 5 to 6 months. MRI pelvis, it showed that there is a, endometrial thickening and it measures 1.9 centimeter with myometrial involvement less than 50%. Cervix, vagina, and parametria were not involved, and there was no lymphadenopathy. Just a second, sorry. Bear with me. So this is the endometrial biopsy of this patient. So as you can see, a very, very prominently glandular morphology, but with areas where there's confluence of glands. A very blue-looking tumor, very confluent. Remember the age; it was 66. So there are these glands which are becoming, confluent. There are areas which are much better differentiated as well. And so a variegated morphology, from areas to areas, you have a heterogeneity of morphology. We started with probably what under the microscope looks like well differentiated or grade 1, FIGO grade 1 endometrium, and have gone to areas which are, morphologically fusion and cribriform, so grade 2. When it loads, you will be able to see that on morphology, these areas which have this confluence of glands, it actually shows a high nuclear grade atypia. And rather than being endometrioid, where as in, it has the atypia that you would actually see in a serous carcinoma because of prominence of nucleoli. Because of prominence of nucleoli, it's not going to higher power than this. I'm sorry for that. There are areas with very prominent nucleoli, but regimented nuclei and pseudostratification like you would see in an endometrioid adenocarcinoma. So this case, this is the MSI panel. Basically, this is MSH2 in this case. So there is partial loss of MSH2. So subclonal loss of MSH2 in this case. This case was ER diffusely positive for ER. Both the areas were positive for ER as well as PR. And in addition to MSI, there was also a subclonal positivity for P53. There was also subclonal positivity for mutation type staining for P53. So because it is being discussed, since morning today, so I wanted to show you what an endometrioid carcinoma with ambiguous morphology or something that is related to a poly mutation looks like under the microscope. So this is what it looks like. Atypia of a serous, regimentation or, elongated nuclei like endometrioid. Subclonal MSI, subclonal P53 can also be positive. Usually strongly ER positive can have squamous differentiation as well. And this sample showed, in addition to this MSI loss and P53 mutation, showed a heterozygous 1 base pair substitution at codon 411 on exon 13. So one of the 4 exons that we study for poly, which have 1 base pair substitutions, exon 13 was mutated. And hence, this is a poly ultra mutated endometrioid adenocarcinoma. In this case, this will be called as a multiple classifier because in addition to poly, it also has an MSI as well as a P53 abnormality on immunohistochemistry. This is a feature which has recently been described in poly, and you must pay attention to this. This, can you see these, these giant cells, or these cells which seem to be falling off the epithelium? This is known as surface epithelial slackening. This has been mentioned recently. Thyroid and serous carcinoma, or a serous carcinoma with an aberrant MSI, was actually a poly ultramutated, and there will be no chemotherapy that will be given to this patient. So these are very important, this is a very important parameter which needs to be studied in certain cases, though 3% is the 3 to 4% is the incidence, but probably in future, based on morphology, we will be able to stratify better which cases need to go for this testing. As of now, the recommendation is to test every patient, at least high-grade endometrial carcinomas. Coming to the next case, 62-year-old woman. So she had a 12-centimeter multilobulated soft tissue mass in the pelvis, inseparable from the fundus of uterus, along with multiple lymphadenopathy. She underwent exploratory lab with TAH-BSO. So this is just a low-pass scanner view to show you that this something blue was actually filling up the, ulcerating the endometrium and filling up the entire myometrium. Okay, so epithelium seems to be like polypoidal, something that we saw back in the cervix also. So what is this kind of a look called? Or what is this kind of a morphology? Like an adenosarcoma type of a morphology, right? When you see that, you have these, epithelium, which is, like bulbous, and then you have something which is growing under it. This area seems more edematous with some cells, but this area definitely seems much more busy and has many more cells. And on hyper, we can see that this is the component which is atypical is present in the or in the mesenchyme, whereas the glands are absolutely benign in this case. And this is just to show you that this is not an adenosarcoma, because the epithelium was just, kind of polypoidal, because it was, because the tumor was pushing it. The rest of the myometrium was filled with these kind of sheets of cells, which at this power appear very, very monomorphic but very blue. Any ideas? So very high grade, considering, look at this necrosis, you have these cells. Again, another, to show you very nested, but very blue, monomorphic, but very high grade atypia. Any ideas on this? Can you describe the cells? What are the cells looking like? Are they looking like endometrial stromal sarcoma cells? If yes, then which type? Low grade, high grade? High grade, of course, no? Because you have so much of necrosis. But what is the exact morphology of these cells? This exact morphology is like cells with eccentrically placed nuclei, and some of them at least have this abundant eosinophilic cytoplasm. Some of them had this prominent myxoid chain. Very infiltrated sarcomas, even lymphomas, can have this background hyaluronidase, which can appear myxoid or mucoid, so be, careful about these. So lot of these cells have this eccentrically placed nuclei with, abundant cytoplasm. So definitely, what this morphology is known as? Plasmacytoid. In the context of GYN, what will you think? Rhabdoid, correct, or rhabdomyoblastic, both possibilities. So we saw that the epithelium is benign, but we need to sample more. Possibilities would be carcinosarcoma. We'll come to that. Again, to show you how malignant these cells are, though they appear monomorphic. This case had nodal mets as well. So differential diagnoses were many. So non-Hodgkin, of course, it was negative. Endometrial stromal sarcoma, high grade, very important. Epithelioid leiomyosarcoma, rhabdomyosarcoma as a component of carcinosarcoma or mixed Mullerian, malignant PComa, involvement by small cell, because we are in the history we heard, or in the examination, that it was, adherent to the uterus. What if it's not originating from it? What is it if it is coming from the pelvis? Undifferentiated carcinoma, which we know is a very monomorphic, and undifferentiated uterine sarcoma, whatever that is. So, these are the different entities. So we ruled out lymphoma. So this is the A1, A3, which is negative. So kind of, dead negative. So possibly carcinomas is low on the cards. Cyclin D1, very variable. Every endometrial sarcoma, which is high grade, needs to have cyclin D1 diffuse positive and BCOR positive, right? This cyclin D1 will not do for endometrial high grade, endometrial sarcoma high grade. So that is out. CD10 focal has no meaning in a high grade tumor. SMA is positive. So anyway, as I said, common things first. So we did, this patient did have a YWHA gene rearrangement, which was also negative. So what else? Desmin, HMB45, all other parameters, that all other differentials, CD30, MUM1, ER, SF, SAL4, all were negative. So what else? What do we do now? What do we always do then when our IHC fails us? We always go back to the morphology. So what did we start with? We started with the look of rhabdomyoblastic versus rhabdoid. Okay, so rhabdomyoblastic I have sufficiently ruled out. What I have not ruled out is rhabdoid. So what are the markers for rhabdoid histology? Sorry? Sorry? INI1, this is 2025. Can't say just one marker. Please give me at least two. So INI1 and BRG1 or SMARC A4, so both. So this is INI1, which was retained, and this is BRG1, which was showing complete loss in the undifferentiated component in this case. So hooray, finally, BRG1 is showing loss. But then BRG1 deficient what? What is this which is BRG1 deficient? BRG1 is like an epigenetic, these sarcomas are like epigenetic. So what is the actual thing? What am I supposed to label this? So then, in the disease that we discussed, there are three entities which can actually show Sweet pathway abnormalities: small cell carcinoma, hypercalcemic type, undifferentiated uterine carcinomas, and undifferentiated uterine sarcomas. So now I need to distinguish. It's just not that BRG1 and then I can just label it whatever. These three need to be further distinguished. So then it takes us to another case. This is another case, practically similar morphology. The entire myometrium filled with these undifferentiated appearing cells. Similar histology, rhabdoid cells. But what do you see here? You start seeing some clustering. And then you see proper gland formation at places and these cords, along with these undifferentiated cells which are intertwining with these. So you had the glands which were fusing and you had the undifferentiated cells. EMA highlights the glands and the undifferentiated component is negative. The glands were ER positive, showed MSI loss, MLH1 and PMS2 deficient, and again BRG1 deficient. So when you have this combination where you have a differentiated component and an undifferentiated component which is showing BRG1 loss, life is easy because then we need to call it the dedifferentiated endometrial carcinoma with BRG1 loss. A clue to pick up is when you have this dedifferentiated carcinoma, which is P53 wild type, think of something else. The dedifferentiated carcinomas, the undifferentiated component needs to be classified. Okay, so P53 is usually mutation type. In the small percentage that it is wild type, think of sarcomas. So this is dedifferentiated endometrioid carcinoma, SMARCA4 deficient and likely MSI high. Now, what is this? This is a 24-year-old woman with an ovarian mass. Look at the, it's like the entire GYN pathology gross looks in one case. Very fleshy, very mucoid, and very hemorrhagic and necrotic. And morphology is this, large areas of geographic necrosis. And this low power picture is diagnostic for this entity. This, yin and yang, this coexistence of this blue and pink areas merging into each other, but with a fine line between them. So the blue areas look rhabdoid. They're not small, but they're called as small. And the pink areas are classically rhabdoid, much more epithelioid. And it has this characteristic follicle-like areas with this, when it is just lined by these tumor cells, these are not true follicles. And this also shows BRG1 loss. And this in the context of ovary is a small cell carcinoma, hypercalcemic type of the ovary showing BRG1 loss. So back to our case and back to the differential. So now, in our case, it was not ovarian origin. The ovaries were normal. So sarcoma versus carcinoma. So younger age, epithelial component is benign, MSI stable, and only SMARCA4 abnormalities. So because of all these features, maybe not young age, but all the other features in this case, and lack of epithelium, which is abnormal, a lack of a carcinoma in an extensively sampled tumor. This is, preferable to be labeled as a undifferentiated uterine sarcoma, SMARCA4 or BRG1 deficient. This patient underwent next generation sequencing, which did show the loss of SMARCA4 and had other abnormalities. MSIH was negative or it was MSI stable and low tumor mutation burden. These are very aggressive tumors. The patient died within 6 months of this diagnosis. But the importance, these are the other tumors in the GYN tract which are SWI/SNF pathway abnormal. And these are important to know now because now this pathway is actionable. We have tazimetostat, which is an inhibitor for EZH2, which is targeting the SWI/SNF pathway. So maybe in the future, we will have targeted therapy. So correct diagnosis is of utmost importance. The other tumors are endometrioid carcinomas. ARID1A is also an SWI/SNF pathway marker. Dedifferentiated, I already show you. Clear cell carcinoma of ovary, just because it is the ARID1A pathway. And epithelioid sarcomas and yolk sac-like tumors of the vulva in young patients. So remember these tumors. Next case, a 56-year-old lady, postmenopausal nulliparous. She presented with abdominal distension. She had, she was found out to have subacute intestinal obstruction. On imaging, there was a 9-centimeter jejunal mass with obstruction in her. Significantly, she had 1 month back only, she had a 17.6-centimeter abdominopelvic mass, both ovaries not seen separately, and she had undergone a total abdominal hysterectomy and bilateral salpingo-oophorectomy at an outside center, which was called as an endometrioid adenocarcinoma, FIGO grade 2. What we received was the biopsy from the jejunal, the obstruction of the mass. Okay, morphology. Case of endometrioid adenocarcinoma of the ovary, FIGO grade 2, 17-centimeter mass. 1 month later, jejunum obstruction with this morphology. Anyone? Does it look like endometrioid? Will you call it an endometrioid adenocarcinoma? Can it be an, what are your possibilities? Sorry? Yes, somebody said carcinosarcoma, right? Somebody missed a sarcomatous component or, and then there was the sarcomatous component has metastasized. This has, kind of, though the cells look more epithelioid, but still some spindling is there, some clearing is there. What else? Very vacuolated, clear, and what do you see here? Very peritheliomatous arrangement. But this peritheliomatous arrangement seems to be a little funny. The cells seem to be running away, rather than coming close to the vessel. Anything else? So if we are looking at a sarcomatous, definitely does not look like an endometrioid, does not look like an endometrioid high grade also, right? Can be a sarcomatous component. Yes, we need to rule out that. But this was A1, A3 very strongly positive. Every single cell. But negative for PAX8, WT1, ER, P16 negative. So what will you do? What will you do from here? Absolutely. That is there is a 17-centimeter mass lying there. Why am I struggling with this practically 1 millimeter, 2 millimeter biopsy? I need to go back to that specimen. So we asked for those slides. They sent us 2 or 3 slides, which actually showed an endometrioid adenocarcinoma, FIGO grade 2, with some mucinous differentiation. Glands, some fusion. In addition, we found some areas which were showing a lot of secretion, clear cell. So yes, in addition, we've also found a clear cell area. So some corded areas also, some areas with this corded hyalinized appearance in the ovary, some areas with clear cell appearance. And one of the sections that was submitted in the original, if you can see, there is this little thing hanging here, When we looked at it on higher power, this is what it showed. A very high grade spindled component similar to the one that we saw in the biopsy. So this brought us hope. So then next, what we did is, this is the high power of that same area. Any idea? You have an endometrioid, you have a clear cell in the same tumor, and then you have something which is looking very, very high grade. Though the cells appear very, very, uniform with prominent nucleoli. Come on. Then we asked for the specimen. This was not enough. So then we got the specimen submitted. So as you can see, this is a very variegated tumor. The solid fleshy areas and the cystic areas were your endometrioid and the clear cell. But this was the area which was, somebody thought it was necrotic and was not sampled. And this is what was there when we sampled this area. Now this picture, everyone should be able to identify. What is this? Correct. Absolutely. Excellent. You guys are phenomenal. Okay, so this is chiller double bodies. So now put 2 and 2 together. So this is just to show you the immunohistochemistry. CK7 positive in the endometrioid and clear cell. ER negative in the clear, positive in the endometrioid. Paxate positive in both. P53 wild type in both. Napsin beautifully positive in the clear. And this component showed GATA3 and diffuse SAL4 positivity. So did the biopsy. We had diagnosed it on biopsy, and that is why we had, kind of asked. So mixed endometrioid and clear cell with somatic yolk sac transformation. Have an eye out. As I said, the poorly differentiated component does not need to be left alone. Think of it, that is going to determine the prognosis of the patient. What came back in a month was the yolk sac. What got this case to our table was the yolk sac component. So we need to identify that, and there is no shortcut to sampling. And whenever you have an odd case in an ovary, go back to the specimen. If you don't have it, get it. Pay for the courier and get the specimen. It will be worth it. The serum AFP was 4100 units per ml. Beta HCG was normal. So this is somatic yolk sac because of the lady's age, and this is not germ cell origin. And because at a molecular level, when these cases were studied, it was found, as was previously told by Dr. Mamta, that these cases had similar mutations as the endometrioid component. So that also has treatment implications. Possibly targeting one will also take care of the other, even though this will be the more aggressive component. The very few cases are there, we don't really know yet. Next case, please let me know. I will stop whenever, Yeah. So 69-year-old lady, postmenopausal bleeding, endometrial thickness of 2.2 centimeter. MRI shows a 5.4 centimeter mass in the endometrium. So a biopsy and a subsequent abdominal hysterectomy. So now this is endometrium. Very clearly some glandular differentiation. It seems so bland that, I don't know, they seem too close, so maybe abnormal. And a very necrotic, very, very necrotic appearing tumor. So 2 components in the biopsy. From both areas, you can see that there is an abnormal glandular proliferation. They have regimented nuclei and abnormal atypia, even though they are not very proliferative. But the other component is beyond mention. It is showing these bizarre cells and lot of necrosis. It's just like the tumor is just withering away. The glandular component, almost like endometrioid grade 1, and the other component. Thoughts? Again, similar, dedifferentiated carcinosarcoma, or something else. If carcinosarcoma, then what is the sarcomatous component? If dedifferentiated, what is the dedifferentiated component? So any thoughts? Just to show you the preliminary IHC, Vimentin was positive in the glandular, negative in the undifferentiated or the poorly differentiated or the bad component. Paxate was also negative in that component. The glands were positive, and ER was positive only in the glandular, and the bad component was negative. P53 was mutation type in both. TK7 was positive in both. Myogenic markers were negative in both, and MMR was proficient. Anything? So as I said, the patient underwent a TH-BSO. It was a very fleshy, looking mass on growth, areas of whitish fleshy appearance, and large areas of necrosis. Do not forget the areas of necrosis while sampling. Do not think that they're necrotic and do not need to be sampled. You know, they also can harbor a second component, a different component. Sampling from all representative areas is absolutely essential in endometrial carcinomas. So as we saw, endometrial component, which in the resection showed varying degrees of atypia. We started from grade 1, but it had confluence of glands and had grade 2 to even grade 3 areas where it was actually becoming solid to undifferentiated in appearance. But these are the areas which were necrotic, geographic areas of necrosis. And now this everyone should be able to pick up. So what are these giant cells and what are these vacuolated cells? Sorry? Excellent. I said I'm proud of you all. So now what is this? There were LVI. You can see the abnormal glands. So there is an endometrial carcinoma and a choriocarcinoma. Again, this is just to show you the somatic transformations of germ cell tumors that can be seen in GYN. A1, A3 positive, GATA3 diffuse. SAL4 positive in this component, metastatic to the lymph node. Both components were metastatic. So this is a somatic choriocarcinomatous transformation as a dedifferentiation in endometrial carcinoma. Or some people like to call it endometrial carcinoma with trophoblastic elements. So, difficult, the terminology is not very clear. The important thing is this needs to be recognized. Beta HCG may be high. And these patients right now, as I said, we don't know how to treat. Some clinicians would prefer to give germ cell-based therapy in some of these cases. Underlying mutations are similar to the endometrial component. Post-op beta HCG was not raised. So rare, 40-50% patients die within a year. And FIGO stage is the most important factor for these patients. Okay, 77-year-old woman, again, C endometrium, big mass, stage 1B. Okay, this is important. 77-year-old woman, 7 centimeter mass. And what do you see? What do you see on morphology? Endometrioid grade 1. Yes? Endometrioid grade 1, very glandular. Anybody begs to differ? Cytomorphologically bit atypical, some regimentation, okay? Maybe some some mitosis here and there. This was also involving the cervix. So this high power is practically to show that there is no basal apoptosis, apical mitosis. Sometimes you may have maybe having that differential. But this is probably what was the 7 centimeter mass because of, you very carefully do not miss your hemorrhagic fragments. Okay, don't just see the viable tumor, see the hemorrhagic fragment. And this hemorrhagic or necrotic, this is not hemorrhagic, this is necrotic tumor. There is no normal cells which look like this. And when we searched and did the serial deep cuts, there appeared this very undifferentiated, poorly differentiated area as well. So this is, this is a combination of something that looks very well differentiated under the microscope and a small area which has poor morphology. But the surprise or this thing with this case is not over yet. Okay, this is the resection. So as I said, very glandular areas becoming very, very solid at places and very blue. These glandular areas were very well differentiated and at places showing a little bit of confluence. But these undifferentiated areas, what do they look like? What do they look like? What is the chromatin like? Correct. Absolutely. So very neuroendocrine looking, very smudgy. And as I said, even the well-differentiated glandular component in this case did not have ER positivity. So while it was very well differentiated, it was also very pink. It was lying in these pink secretions. Okay, so that is also something that we need to look at, especially when we have well different. So when we have this ER loss, you heard it in the talk. So when we have this ER loss in a tumor that looks very well differentiated under the microscope, immediately what is the thought? Correct. This is mesonephric. This case, I brought the context of cervix because this is involving cervix. P16 is positive. And here comes the understanding that P16 is just a surrogate. Like serous, any high-grade endometrial carcinoma can also show P16 block-like positivity. So don't just rely on, P16 as your marker to classify it as cervix. ER was also negative. So actually that goes in favor of cervix. But this case again had subclonal P53, one component mutation type, the other component null type. So very aberrant kind of immunohistochemistry. The resected areas, the undifferentiated areas did show synaptophysin positivity, INSM1 positivity, GATA3 and TTF1. So this is actually a mesonephric-like adeno with neuroendocrine dedifferentiation or a mixed. The criteria, why am I keeping both these differentials? The reason I kept this case is one, to show you that these mesonephric carcinomas will get called as endometrioid grade 1. Now you see the staging is different. The moment I say mesonephric and involving the myometrium, it is 2C. Whereas a grade 1 endometrium will not be, just limited to the endometrium, will be 1A. It is a huge difference in management for these patients. And most of these patients will come back with distant metastasis. It has become a thing with me that, a patient labeled somewhere as grade 1 endometrioid now presented with lung mets. The first thing I, in my mind, will think is ER negativity and TTF1 or GATA3 positivity. So these mesonephric will come back at a distant site. So do not miss them at the primary. So this TTF1 and ER are very good first line screens for identifying this tumor. This has the KRAS mutation. It is not following the ARID pathway. It is a very different molecular profile. And this is aggressive. By morphology, this is an aggressive according to FIGOS 2023 classification, lung mets and pelvic recurrences. Also with this case, I wanted to give you the concept of the newly recognized neuroendocrine differentiation in endometrial. So what are the cases where we can get it and how do we classify? So it is very rare, less than 1%, mostly mixed. So you will have a neuroendocrine and a non-neuroendocrine, postmenopausal women. The neuroendocrine component is small cell or large cell, and serous endometrioid or clear cell is the usual. Neuroendocrine marker and P16 positivity. Here P16 is because of neuroendocrine, because of a high-grade tumor and not because of HPV. Cervix is the primary site of neuroendocrine in GYN and must always be ruled out. Like for carcinosarcoma of cervix, rule out endometrium. Here, rule out cervix. And rule out non-neuroendocrine carcinoma because focal neuroendocrine markers can be positive in any, high-grade endometrioid carcinoma. So look at the morphology and then look at the marker and then think of a neuroendocrine component. This is the current classification that less than 10% area with neuroendocrine marker expression is acceptable for dedifferentiated. So if your neuroendocrine area is less than 10%, you can still call it DDIF. If it is more than 10, you have to bring in neuroendocrine as a separate component because then it has therapeutic implications. They might like to give neuroendocrine type of chemotherapy, which is very different. These neuroendocrine carcinomas are Paxate negative and, maybe MSI high. Just to show you some literature. Another case of ours, very different neuroendocrine. Here the two areas were very different from. This is a classical endometrioid and with neuroendocrine areas, more than 10%. So here we call it mixed. So all these cases were shown to you to make you understand that dedifferentiated endometrial carcinomas is a new and evolving concept. Right now, we are just supposed to call something as dedifferentiated when we see an undifferentiated carcinoma and a differentiated component and differentiated from carcinosarcomas where you have the bad component is actually a sarcomatous component. However, it has a spectrum and the poorly differentiated or the bad component needs to be classified further. It could be a Swiss-Nef pathway type of tumor, it could be a neuroendocrine, or it could even be a germ cell. The differentiated component, as of now, whatever studies say, is clonally related to its differentiated component. And my talk will not be complete if I just don't show this very important scenario. So this is a 45-year-old woman with increased facial hair and irregular periods, and she was found to have an 8 centimeter unilateral ovarian mass. Very pink, very nodular. So what does the low par look like? Very pink, very nodular.
I think you can continue, Neha, so that we can finish off with this case.
So very thecomatous, very pale, pink, very thecomatous, multinodular type of growth. Yes, agreed? Just to show you, very pale, and you have this pale stroma running in between these nodules as well. Again, very, clustered appearing cells, but again, very pale with presence in this, these cells are present in this very vacuolated kind of cytoplasm. Again, as I said, gray appearing nuclei, very thecomatous look, with scattered fibrosis, maybe somebody thecoma, fibroma, though fibromatous component doesn't seem to be that. Very bland appearing nuclei, very vesicular appearing. But at the same time, now when you see it at high power, you see that some grooves start appearing. So, a pink granulosa, colorblind granulosa, it didn't know it had to be blue. So this is pink, but you are saying it's a granulosa. So now what do I do? So when do you have this combination? Yes, very good. Yes. So these are various combinations where you can have luteinized, hepatoid, and the third, which is this one, is they're called as granulosa with thecoma-like areas or thecomatous granulosa cell tumors. And the key to diagnosis is not any IHC, not any molecular, but a good old reticulin stain. Okay, when this reticulin stain shows clustering around cell groups and not individual, that is when you will diagnose a granulosa and not a thecoma. A thecoma cannot have this kind of a reticulin stain pattern. This is a relatively new subset which is being understood. It is rare among the granulosas, this thing. But here, as I said, this is very important because here we are discussing a differential between a benign and a malignant entity. So adult granulosa cell tumors are malignant, whereas thecomas behave in a benign fashion. So this is one last case to show you a very poorly differentiated tumor. Again, ovarian mass. From here, you cannot make out anything. You start doing markers, everything was negative here. So that is when in ovary, in endometrium, you have to start looking for this. What are these? Endometrial or glandular or tubular differentiation. Okay. And then common things first, EMA is negative. The moment you have something which looks like epithelial but EMA is negative, we are in the realm of no, not really. Epithelial looking. Maybe yes, you are talking about yolk sac, correct. But this is very, very glandular. Yes, yolk sac also, but what was the age? Yeah, this was a young woman. Okay, you have very pleomorphic cells, very variegated appearing areas, and then this kind of tubular differentiation. Yes, you can rule out, yes, EMA, SALFOR needs to be done as well. But this is also a scenario for FOXL2 and SF1, which are your sex-caused stromal tumor markers. So this is what I meant by poorly differentiated Sertoli-Leydig cell tumor, a case for DICER1 mutation when I showed you the other DICER1 related tumor later on. These are my acknowledgements.
So
Thank you.
Thank